like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is the role of specialists in value-based care. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan. How are you doing?
Hey, Faisel. It's great to be with you this evening.
It is great to have tonight's topic. I'm really excited to have this conversation about the role of specialists in value-based care. And joining us tonight is our very own Dr. Scott Tromanhauser. Thank you so much, Scott, for joining us tonight.
Happy to be here, Faisel and Dan. Thank you for inviting me.
You know, one of my favorite, when I was in residency, I mean, there's a lot of fun times in residency. I did my training at an unopposed family medicine program, and I loved the morning coming into the doctor's lounge, and there were always those attendings that we could curbside, and I miss that. I miss that in my regular day-to-day life now. So to have you come on tonight to talk about the role of specialists in value-based care is particularly fun.
Great.
So I wanted to know, how did you, I'd like to know about how did you make your way to ChenMed as an orthopedic surgeon coming to a primary care geriatric practice?
Yeah, it's funny. So many people ask me that, and occasionally I ask myself that. But I'll tell you, it was a long journey. It started 15 or more years ago. I spent my career, some 27 years, at a world-class orthopedic surgical hospital. Really doing great work, dedicated private practitioners, delivering the best care, demanding the most of themselves and everyone around them. Because of that, we attracted the attention of Michael Porter and Elizabeth Teisberg. And Michael Porter's at the Harvard Business School. Elizabeth was at Darden in Virginia at the time, and they were writing a book that has become the sort of I'll call it the Bible of value-based care. It was published in 2006 called Redefining Healthcare. And I had many conversations with Elizabeth and ultimately Michael, and I've been involved off and on with Michael Porter's effort at Harvard Business School to get the message out about value-based care. And I went on to do a master's program in healthcare delivery science at Dartmouth. Elizabeth Teisberg was sort of the keynote person who had been recruited up there. So my journey just continued. I finished that program 5 years ago. And then you get to the point where you have the burden of knowing. So that comes from a term my wife came up with. She went to Africa 15 years ago to do some work in Zambia. And when she saw what she saw there, she's an OBGYN, she said, it's hard to turn away and want to do anything else. She said she had the burden of knowing. So I had the burden of knowing the problems within the fee-for-service system. And they become more and more obvious the more you learn. And so this opportunity came a-knocking, and I looked at this. It took me 3 seconds to understand what ChenMed's challenge was as a primary care organization. And I said, I got to get this job. I love this. And here I am, and I could not be happier with the choice I made.
Wow. You know, from my community health days, one of the biggest complaints I had from the specialists that partnered with the community health center was that, the primary care doctors aren't doing the proper workup. I'm spending all this time as a specialist doing primary care work. And it would go on and on, all different. It didn't matter what the specialty was. pick it, urology, orthopedic surgery, whatever it was, and even to the emergency room doctors. They would say, hey, most of what I'm doing over here could be managed by a primary care doctor on the outside. And when
You're
we connect
absolutely
with
right.
doctors,
And
yeah, no, I was saying that
so
when we connect with doctors outside, they're like, yeah, but we just don't have the time.
that's true. And I put together a team of 11 specialists, all the major specialists you might guess: cardiology, orthopedics, neurology, nephrology, and on, the big ones. They all came with the same point of view you just expressed, that so many of the consults that they saw in their office were unnecessary, no workup, and they wound up doing the simplest things for these patients that primary care certainly could do. And that's part of the role they're playing at ChenMed, which I'll let you take us there, Faisal, when the time comes. But we've all recognized that much of what we do as specialists is really simple stuff.
My
I'm
dad,
trained
when
as
he
an
joined.
orthopedic.
Oh, no, please.
I'm trained as an orthopedic spine surgeon. I'm sorry to interrupt.
No.
And I had the luxury of being able to screen patients to see me in the office, but I had some colleagues who had PAs who would let anybody in the office who that one day of back pain, and most of back pain can be cared for conservatively. Didn't need surgery. Going to see an orthopedic spine surgeon for conventional low back pain is equivalent of seeing a cardiothoracic surgeon for your first episode of chest pain. We just don't do it that way. And, a primary care doc is capable of taking care of that first episode of chest pain. Maybe you might want to get a cardiologist involved at some point. And primary care is perfectly capable of taking care of simple problems like knee pain, shoulder pain, back pain.
Do you think that there's a way in the fee for service world for some more efficiency? Because we know what the life is like. 95% of the system is still based in fee for service. But is there a way to have some efficiency in the fee for service model when the primary care doctors have all the burdens with the paperwork and all the bureaucratic, everything that's involved with their day-to-day lives? They're not even averaging two visits per patient per year.
So I think there is, and I think it's about relationships. You have to develop relationships between, primary care docs and specialists, and in some communities that exists. Obviously, smaller communities,
Sure.
everybody kind of knows each other. It probably works better. Where curbside consult is easier to get, or your neighbor is, the urologist or the neurosurgeon, whatever it is, it's easier. But in a big metropolitan area, that doesn't work so well. I think it's a challenge. It's a real challenge. I'm not sure it's achievable the way we achieve it at ChenMed. So I don't have a good answer for you.
Well, in value-based care in general. So in the value-based care world, I mean, you could try to simplify value-based care. There's three general types of value-based care models. There's the shared savings. There's some downside risks, these hybrid models. And then you got the fully capitated world, the world that we're in right now. But now in value-based care in general, what do you see the role of specialists in the value-based care world at large?
So I say this to my team all the time. If everyone practiced evidence-based care, we'd have no ChenMed. There would be no need for it. We wouldn't need all these elaborate risk-bearing arrangements. It's about getting people to do the simplest things in their office. It's about getting specialists not to add on testing, procedures, understanding what's a low-value procedure, getting away from this system of RVU tallying. It's really a ball and chain. On the other hand, primary care docs really need to learn what we're seeing at ChenMed. They just learned the major problem in each of my 10 specialties. It would be enormous. if you just understood as a primary care doctor how to take care of knee pain and low back pain, if you knew how to take care of how to supply a patient with the oxygen they need for their chronic lung disease, if you knew how to care for most of the stages of chronic kidney disease, it's not that complicated as it turns out. Even I understand it now because I came in not understanding any of it. If you could just get that one major problem in each specialty, it would be a huge impact for your patients. We're trying to teach them those things, and I realize every internal medicine program and even family medicine program doesn't have the time, doesn't have the resources to get primary care docs to expose to all of these things. I get it. But, somewhere along the line, you learn some fundamentals through medical school, and you did learn some stuff. It isn't much further to add on a layer above that I think could really be beneficial to patients, not to mention more satisfying, I would think, as a primary care doc.
Yeah, Scott, I came from the University of Virginia, and I saw the transition over the 30 plus years. And going back to the time when I was a resident, you really did get a lot of feedback on your referrals and how you could handle things yourself. But over time, it seemed like there was the mindset that everybody was going to grow and take market share from everybody else and wanted to provide all these services. So we want to build the operating rooms, we want to buy the robots. And, I went from a time when I can remember I was the senior resident in the emergency department because we didn't have an emergency medicine program at the time. And the first President Bush was visiting Charlottesville, and I had Secret Service agents in the emergency department, and I had to ask them to leave because they were taking up so much room. Stretchers couldn't get up and down the hallway. And, assured them if the president was injured, we would make space for him in a moment's notice, but it wasn't going to help if people were lined up out the door when he got there. But, I think part of it over time is we've trained so many specialists. I mean, we've trained, we in most of the European countries, it's 70% primary care and 30% specialists. In this country, it's exactly flipped. And so now you're trying to, I remember at one point I was having a discussion with one of the surgical chairs, and they were saying, well, why can't you get the patient in to do the pre-op visits? And I'm like, well, you want me to do the pre-op visits. You want me to be available to see the patient as soon as they get out of the hospital. Oh, yeah. And if the patient has a complication and they're not doing well, you want me to come to the hospital and be able to talk to them about that. And oh, yeah, well, and I need to have my schedule completely packed to make sure that I'm making good use of all that time. So exactly. And all of your colleagues would like for me to do that. So how do we make that work? I mean, I see what you're talking about, but I'm stunned that residents are not even getting good feedback on when they do referrals. I mean, it was a matter of pride when I was a resident to, you had to get the attending's permission before you sent somebody to a specialist because we wanted to take care of everything we could. And now they're just asking them to do so much that residents are just, if they think about it, they're sending a referral out very often.
I understand that, and I get that challenge. I don't know the entire solution to that problem, but I will say that it's unfortunate that training has gone that way. I remember, it's like a couple of geezers here. I remember as a resident, there were no, people don't remember this now, at least younger people, there were no emergency room. That wasn't, no ER docs. That wasn't a specialty. There wasn't a thing. So the ER was manned by surgical residents and medicine residents. And, you got much more experience doing that. And something was taken away there in the training system. I remember as a resident, if I'd got a ridiculous consult from a medicine resident, we'd just tell them we're not going to do that. You could do that. I remember I got a consult. Somebody thought that someone's wrist was septic and they wanted to aspirate it. They called orthopedics to aspirate it. And I said, I absolutely will not do that. I'll come and show you how to do it, because if it's obviously uh, infected, you probably won't have any trouble finding the spot where the pus is. And that resident really appreciated that, and now is able to do that again. I think there's this fear. It's a little off topic, but there's this fear amongst some of the primary care docs we have that the care that we're providing as specialists is more complicated than it really is, and it's not. And so when they finally learn, oh, that's all you have to do, okay, they just were never taught. So now we're trying to be a combination of curbside consult, teacher, mentor, guide, best friend, salesman. Try to say, listen, you can do this. You can have pride in primary care. We'll help you do that. It's not that difficult.
Yeah, there's definitely that, the benefit of the curbside. It happens, and we've talked about this. It happens when the teams become very familiar with one another and they just feel comfortable. Hey, I just want to run this by you. Not a formal consult saying so many year old whatever male who's presenting with this blah 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 blah, and this whole detailed consult note. I mean, just a quick ask saying, hey, I've been struggling with this, whatever the situation is. What do you think? That's it. It helps so much. And many times the doctors know. Yeah. Many times they know already. It's just a confirmation. They get it from someone. Oh, okay. Thanks.
It's funny you say that, Faisel, because we just did a survey of our PCPs to ask them how they felt about it, the curbside consults we were providing, and almost a half said that it changed their thinking about the problem, but 30% plus said it confirmed what I already thought. I just thought that was wonderful. They didn't have the confidence to move ahead. They asked for a curbside consult. But you know what? How many times are they going to have to do that before they say, oh, yeah, I know what to do now? They won't ask for that curbside anymore. So I was really happy to see that we were just confirming. And I tell my specialists, every chance you get, you got to pat them on the back and tell them, good job, you did a great job. That's exactly the way you should be thinking about this. Because it's, many of them at times feel embarrassed to ask questions of our specialists. I don't know why we must think they need to know everything. You don't need to know everything. I think a real sign of strength is asking for help. It's weakness not to. So I think it's really a sign of strength to say, hey, help me with this. And you'll learn every time you do that. And eventually you won't have to ask for that particular problem. There'll be another problem you can talk about.
Exactly. Well, I would like to take a quick 20-second commercial break. And then I'd like to talk about the role of specialists in the full risk model. So let's take a quick break and we'll be back in about 20 seconds.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. I was in St. Louis a couple of days ago. We have 3 centers there. I got to meet with our doctors. We're about to really take things to the next level. The market's really ready for growth. And I met with one of our doctors. They're all, the 3 of them there are family doctors. One of them is very comfortable with doing joint injections and procedures. Another one's in between, and then one of them told me, she said, I'd like to do them, but I just don't feel comfortable doing it. I would like someone to come show me how to do some of the common ones. And I said, yeah, we could arrange that. The look on her face, she said, you're going to have an orthopedic surgeon come here to St. Louis. I said, yeah, absolutely. We could do a workshop on common procedures. And she was so thrilled. And I know that's just that's unheard of. That's unheard of.
You're absolutely right. The access that our primary care docs have to specialty care is entirely unique. Doesn't exist in the market in the same way. I mean, our specialists, these 11 people, are literally there as concierge for the PCP. They're like that like that public television commercial for 1970s music. Just pick up the phone. People are standing by. Literally, and I'm not kidding, that's exactly the way it is. There are other ways for them to reach out. We have secure texting and other things, as you know, and that works really well. I just got some statistics the other day. Since June 1st, we've had close to 1,500 outreaches from primary care docs to our specialists.
Wow.
And that's huge because some of those are definitely resulting in fewer referrals out to specialists. And the reason we want to avoid that is because when we send our patients out for a specialty referral, it's out-of-pocket expense for the patient. And if they don't have that $20, $30 or whatever it is, they're not going to go to that appointment. They also have problems with transportation. So if they don't go to that appointment, then they're not getting the care they need. And that's not what we want at GenMed. So, along the same line of the story you told, Faisel, our orthopedic national specialty director, Dr. Brian Gordon, has been to at least half of our centers to teach the PCPs about a joint injection, shoulder, knee, primarily, which are really a lot easier than you think. The knee you could do with the lights off and a blindfold on, because it's just such a big joint, you can't miss it. But we've had a couple, I'll call them testimonials, from some PCPs who wrote to Brian afterwards and said, I did my first shoulder. The patient's pain was gone before they left the office. It was so great to see that. The patient was so happy and hugged me, and that that doc felt so good that they could provide that right then and there, solve that patient's problem, didn't have to send them out, not to mention they'd wait for weeks for an appointment. So, we solve a lot of problems by dealing with them this way with our specialists.
It means a lot. I haven't used. I don't have a large panel of patients, but I've got a few that I see, and I sent a GLIP to one of the specialists one day, and it was like an hour later, and they were responded, and it wasn't an emergency, and they were just profusely apologizing for taking so long, and I'm like, are you kidding? I've got a specialist who's answering my question, and it's the same day. I mean, I was just going to be happy if I got an answer in 24 hours. I wasn't in any big hurry, and they felt like they'd let me down because it had taken an hour because they were helping other people. And like I said, it wasn't an emergency. I knew I could have called had it been an emergency.
So Dan, I got to tell you, I'm sorry that it was an hour, because I set a service standard of 15 minutes and no more than 2 hours, just because sometimes they're in meetings or they're doing something or they're traveling. So yeah, the service standard is to try to respond within 15 minutes.
Yeah. Well, like I said, I was impressed at an hour, and so I guess as long as you were certainly exceeding my expectations at that point. So I just
That's great.
But I mean, the patient didn't have to go anywhere, and I was able to give them a phone call and tell them, here's what our plan is, and so it worked out incredibly well.
That's great. That's what we
yeah,
want to hear.
That we have centers where more than 90% of the patients rely on us for transportation services. St. Louis, one of the centers I was just at, more than 90%. And my father is a GenMed patient in our Tampa office, and he was seeing specialists before joining us. He had 5 specialists. Every couple of weeks, he had a doctor's appointment. And the stress of just having to see these specialists. By the way, none of them were talking with each other. He didn't have he had a PPO. He didn't have a primary care doctor, and none of them were talking with each other. And just the stress, the burden of having to go see. And he said nobody was doing anything different. Every time he was seeing the specialist, the cardiologist was saying, continue the current regimen. The neurologist was saying, no signs of dementia. Continue. Everybody was kind of just keeping things moving along. And that's the state of affairs for most people. Yeah. Most people experience that. People who require seeing doctors aren't having interventions. It's just kind of just like, stay the course. And I don't see that happening anymore, at least in our bubble.
Right. We are really aware of that issue and trying to control that that need for the follow up. Oh, just come back and see me once a year, twice a year. Well, for what? Give the primary care doc the plan, tell them what they need to do, and we'll follow up if and when needed. You don't need these standard, repeated, endless appointments where nothing happens. I agree. That's just wasteful. It's wasteful, period. And not to mention the out of pocket for the patient, the travel, everything else. It's really centered around the doc and not necessarily the patient. And we are, we try to curate who our patients go to see. And if we see a lot of that behavior, we'll take someone right off the list. We'll try to reach out to them and say, hey, that's not kind of how we work here. And this is how we work. This is value-based care. We'd love, the patients love you, but your downstream costs are high. You are, you're spending money you don't need to. Can you come in line with our model? If not, we find somebody who can.
Right. And I think the important thing about that is it's not only we are fully capitated, so it is a big chunk of that is our money, but our patients average about getting by on $1,000 a month, and even if they're paying what we would consider a minimal copay, if it's creating extra visits, you're asking them to make a decision between getting some more fresh fruits and vegetables or going to see that specialist. And it is, I mean, more and more we're realizing how much the social determinants of health play into healthcare. And so the more that we can keep the cost of healthcare from interfering with their ability to do what they need to do is very important for them. I mean, it's not just about the money, it's about them being able to eat, them being able to pay their rent, them being able to buy their grandchildren an ice cream cone if they want to, any of those kind of things.
You're right, Dan, and I absolutely. And as I started in this journey, as I was explaining earlier, 15 years ago, even when the way I practiced changed, although it was highly specialized. I went from don't send your patients for an MRI to a hospital facility because there's a facility fee. Send them to a freestanding MRI unit. Was one way you can help your patient. And I used to send them all to my hospital because it was convenient for me because I had access to the scan easily, right? Well,
Sure.
guess what? I found other ways to do it. And other things like the cost of the implants we would use when we used implants, where they went after they were discharged, what medications we chose. I started to think about all of that stuff as a specialist, and we talked a lot about it at my hospital. And but I think a lot of specialists just aren't aware. They just don't understand. We all know this. We know that not all providers understand the social determinants of health and how that affects them. And you're exactly right, Dan. It could be the difference between groceries for a few days or medical care. It could be that bad. And we all need to think about that. Everybody needs to be aware of that. And I wish there was more of this sort of thing taught in training programs. When I started a year ago this week, I started with 4 or 5 new PCPs. 4 of them were right out of training. One was out 5 or so years. The 4 that just came out of training had no exposure to value-based care delivery at all during training, admitted they'd never heard the term until they were recruited and hired by ChenMed, which I just thought, oh my gosh, look where we are. And it's 2021. And we've been talking about this for 15 plus years, that people still don't get it, still aren't hearing about it, still aren't being taught. And I get why. All their mentors are of a generation that isn't involved with it in the same way we are. So I get it. And there's going to have to be this generational change in order to get everybody to where we need them to be to really function in a value based model. And you both know we have to work hard to train them up to understand this model. which we're absolutely willing to do for anybody who wants to join us. It's you can learn it. It's not that complicated.
A couple of years ago, we started hearing. So we spend a lot of time giving residency lectures, internal medicine, family medicine programs. We go around giving lectures on value-based care. And a couple of years ago, it was in 2019, we started hearing about interns would brag to us that they're memorizing CPT codes. And I didn't know anything about billing when I finished my residency. I remember my first job. I told him that I didn't know how to bill, and the center manager said, "Oh, that's okay. Just put 99213 for everything." But now the intern, yeah, that's what it was. And a couple of months later, I had over 400 charts I had to redo it. That was a mess. But now we have interns are actually learning about CPT codes in their internship year. That's the state of affairs right now with medical education.
That doesn't surprise me. I was the same way, Dan. You probably were too. I came out and took a couple of years for me to figure out how to do it. I went into solo private practice. It's a wonder I made any money. I got anything done, and that's just a shame. That's a shame.
Yeah. I said that you guys got to learn how to run codes, not billing codes, because that's what's going to happen. That's when you learn. You're gonna. Everybody has that moment when you're an intern and the second year's not there, the patient's crashing in front of you, and the staff look at you. Okay, doctor, what next? And if you're filling your mind up with billing, I mean, you're not learning what you need to learn as an intern.
True enough.
Well, Dr. Scott Tromanhauser, thank you so much for joining us tonight.
Hey, this was fun. I never tire of talking about this stuff. I have a saying that all my people hate, which is say it, and say it again. So I just keep saying it again and again and again. Thank you for inviting me.
It was great to have you on. Dr. Dan, have a good night.
You as well, Faisel.
And to our audience, thank you so much for joining us this evening. For more information about tonight's topic and to explore career opportunities with ChenMed, remember, we're on track to open another 500 plus centers over the next 4 to 5 years. You're talking another 2,000, 3,000 plus primary care doctors, plus all the teams of people to support them. Please visit chenmed.com. We believe access to primary care is a right, not a privilege.